Hello everyone, this is Joe Minardi coming to you from West Virginia University Emergency Medicine, and what I've got for you here is an introduction to bedside ultrasound in first trimester pregnancy complaints. And what I hope to do is, again, give you an introduction and help you rule in intrauterine pregnancy so that you can hopefully conclude that ectopic pregnancy is very unlikely in first trimester pregnancy patients, and then help you reassure them, help you get them through your department faster and make diagnoses at the bedside, and especially when maybe radiology ultrasound isn't available at night times, weekends, so that you can take better care of your first trimester pregnancy patients more efficiently and quickly in your emergency department. So, moving right along into some of the complaints or reasons these patients show up. We all know this, we've seen this. Usually it's vaginal bleeding, abdominal or lower pelvic pain, and then rarely sometimes they may present in shock. And that's really not exactly the patient we're talking about now. We'll talk about that in a more advanced time later on. So usually we're talking about patients with vaginal bleeding, abdominal or pelvic pain who are either suspected or known to be pregnant, or maybe they don't know they're pregnant yet, but you figure that out that they are. So in first trimester pregnancy, the most important objective that you have is to identify ectopic pregnancy. And now what we're going to talk about is identifying intrauterine pregnancy, and in patients with a normal intrauterine pregnancy, then ectopic pregnancy is really unlikely. So that's the way we're going to go about this. We're going to rule in intrauterine pregnancy. And just to tell you why is ultrasound so important, this history and physical is really inadequate to exclude ectopic or even rule in an intrauterine pregnancy. History and physical just falls short at making this diagnosis. So this is like our overlying theme, something that we have to keep buried in our brain, and we need to know this, is that the ultrasound diagnosis of a properly placed normal intrauterine pregnancy makes ectopic pregnancy highly unlikely. And that's how we're going to approach this. Not really identifying ectopic or 100% ruling out ectopic, but finding a normally placed intrauterine pregnancy along with some of the historical risk factors, and this can help you pretty reliably exclude ectopic pregnancy. So this is our underlying theme, yes or no ultrasound question is, do you see an intrauterine pregnancy? And I'm going to add in properly placed, and we'll talk about that. So rule in intrauterine pregnancy. I'm not sure if I've beat that point to death enough or not, but that's our goal here. I like to throw this table in here because I think it just points out, and when we'll talk about doing transabdominal versus transvaginal ultrasound, why I think transvaginal ultrasound and being comfortable with it and doing it and owning it is important in emergency medicine practice. If you take a look at here, around 7, maybe even 8 weeks before you see the first true signs of a true pregnancy, which is the Yolk Sac, and with transvaginal we can see this as early as 5 to 5.5 weeks, and it seems to me like right around in here is when a lot of these patients present, and if we add transvaginal we can really make a more accurate diagnosis and take better care of these patients. So I am going to emphasize getting good at and practicing transvaginal ultrasound. Just to orient you a little bit to what some of the anatomy looks like, we'll start with transabdominal because often when you walk in the room that's what you're going to have. This is the first thing you're going to do is the transabdominal ultrasound. So we'll use the curvilinear probe. I'll talk about that. And if you start with a sagittal view, so then patient's head is up here and their legs are down here. This is our probe. Indicator is directed toward the patient's head. And we'll see the bladder, which may or may not be distended. Most of the time in our patients it's not. And then sitting behind that in most patients, an anteverted, slightly antiflexed uterus we'll see behind the bladder. And here we see, and this is a more typical emergency department patient where the bladder is already emptied out, and we can see the uterus antiflexed and anteverted, and we can also identify the endometrial stripe. This is the fundus up here, the body of the uterus, cervix, and this is the vaginal stripe. Don't mistake this for endometrial stripe here. Just another cartoon diagram showing here's a more full bladder. This is all uterus here. There's a fairly thin endometrial stripe. The cervix is down here. This is the vaginal stripe. Don't confuse this again for endometrial stripe. That can be a common mistake. And here again we're using the lower frequency probe, usually the curvilinear, although you can use the phased array probe if that's what you have available. When we turn coronal, so now we have the indicator directed towards the patient's right. So this is right, this is left, superficial and deep. So we see the full bladder here, and behind this we see this relatively homogeneous muscular structure. This is the uterus, or somewhere in the body or near the fundus here. and this is the right uterine horn and left uterine horn. Here's again a sagittal view showing the bladder, and then the sagittal view of the uterus, cervix, body, fundus, stripe. And I'm just going to go over the orientation of what a transvaginal first trimester ultrasound will look like. And the advantages of transvaginal probe, it's higher frequency. So if you remember from some of our intro talks before, a higher frequency probe gives you more detailed imaging. You lose a little bit of depth, but in this case we're putting that probe very close to the anatomy, so we don't need a lot of depth. And like I said, it's in close proximity. Some studies would even say, at least in radiology suites, it's better tolerated, and that's probably in patients where the transabdominal means pushing on a fully distended bladder. But for us, the biggest advantage is more detailed imaging. We're able to make diagnoses earlier, and then when we get to advanced topics, we'll talk about doing the complete ultrasound yourself at the bedside, and we can really kind of just own the whole first trimester ourselves. But for this intro, we're talking about ruling in intrauterine pregnancy today. So with the transvaginal or pelvic ultrasound, the technique, the patient should be in the lithotomy position, and to me this is usually just the next step after I do the vaginal exam and the pelvic exam. So I bring the ultrasound in with me, I've done the pelvic exam, and then I just do the ultrasound right there without having to move or do anything or any other setup. Ideally their bladder should be empty, so if their bladder's not empty, it's nice to let them empty their bladder before you do the pelvic exam and the ultrasound. And then we'll mention that the indicator only has two positions for transvaginal ultrasound. It's either towards the ceiling for sagittal views or towards the patient's right for coronal views. And we put gel at every layer, so we put gel on the probe, then we cover it with a condom or a specialized probe cover, and then we put more gel on top of that, preferably sterile gel. And I think I said this already, the indicator has two positions. It either is directed towards the ceiling or towards the patient's right. And obviously practicing this technique in a hands-on lab setting is more valuable than hearing me talk about it, so I'll go through the technique fairly briefly. But just to orient you a little bit, this is what a sagittal view would look like in the majority of your patients. One of the first things you'll see is the bladder. And just to point out what this imaging with this probe looks like, we've got this tight curve at the top and this very wide field of view. We see the uterine fundus. Very important to make sure you see the fundus, so you've imaged the entire uterus. In this scenario, the patient's head is here, this is anterior over here, and this is posterior. And the patient's feet come from the screen here. Here are some cartoon drawings of how that slices through the patient's body. Here are coronal views. The indicator is now directed towards the patient's right. So this is right, this is left. Patient's head is still here at the bottom of the screen. So the head is always at the bottom and the feet are always at the top of the screen in transvaginal ultrasound. So again, just comparison views. Here is a sagittal in again an anteverted uterus, coronal view, and for orientation you can imagine the patient's head directed down at the bottom with the face this way, and for the coronal views, head is at the bottom but it's the back of the patient's head. This is right, this is left. So initially, again, often you might see the bladder first off. Now this is when it's a little bit more distended. Ideally you'd like that a little bit more empty if possible, but if you see this, then you should be able to identify the uterus, the endometrial stripe, and the uterine fundus. And here now we've just advanced the probe a little bit further, so we're past the bladder and we can see the majority of the uterus. We're cutting off a little bit of the fundus here. We just make sure we want to see that, but we see all of the uterine fundus pretty much, the body, and here we can see almost all the way down to the cervix, and we can identify the endometrial stripe. And in here what we see is multiple loops of bowel with fluid and stool, which you may see sometimes. Now in some cases you may see a retroverted uterus. This is the minority of the time. However, what you'll notice is the uterus is just tipped posteriorly. Remember, the patient's head is here, this is anterior, this is posterior, so this is just a retroverted uterus that is directed posteriorly. Still important to make sure that you identify the uterine fundus. Alright, we go back to coronal views. Now our indicator is directed towards the patient's right, so this is right, left, head, and feet. We see the body of the uterus, we see the endometrial stripe in a coronal section, so it kind of looks like a oval or trapezoidal image. And in this case we actually see the ovary sitting right next to the uterus. Sometimes it will sit here, and that's just important to keep in mind that ovaries can sit very close to the uterus, and you should make sure that you look there. So imaging the adnexa, I like to start from a coronal position, so we have a uterus that looks somewhat like this, and we want to have the slice somewhere through the mid portion of the uterus, so where it looks relatively big, and then we just direct the probe to one side or the other. The indicator should be at the patient's right, and then we usually will have to advance the probe or apply a little bit more pressure just to push past bowel gas and other things to get to the ovaries. And we're going to sweep very widely from the floor to the ceiling until we can hopefully identify the ovaries next to the uterus. They should be roughly oval, they should have a well demarcated outline, and they often will have identifiable follicles within them, and they're always medial to the iliac vessels. It's one of the few things you can rely on in medicine, is ovaries are always medial to iliac vessels. So here's an example where we started with a coronal view of the uterus. We can see again, ovalish endometrial stripe, and then on the left side we'll see an ovary. We see some follicles within, and here's an iliac vein that we can see, and this is on the patient's left. So there's iliac vein, and there is a follicle within that ovary. And then over on the right side, so the patient's right, we see the iliac vessels here, and we see a well demarcated outline of an ovary with follicles within. Don't confuse this with some of the uterine vasculature that is very prominent and common in females of childbearing age. You see a nice outline around this ovary, whereas here we see this kind of random vasculature with no organization to it whatsoever. And if you put color, these should all light up with color, whereas follicles should not have any color flow within them. So there's our iliac vessels laterally, and then more medially we see the ovary with identifiable follicles. Now, we're not talking in detail about the adnexa today, but I do want you to, even from the very beginning, I want you to practice imaging the adnexa, and then as you get a little more practice under your belt, we'll talk about advanced and just owning all the diagnoses in the first trimester, imaging the adnexa, identifying ectopic, and things like that. But for now, we're focusing on mostly the uterus and finding intrauterine pregnancy. So the stages of pregnancy, I want you to be really familiar with these. The first thing that you'll see early in pregnancy is just a simple gestational sac, and this should be located within the uterus, fairly central, fairly high, with a significant thickness of myometrial muscle all around it. There are numbers and measurements for that. I don't like to get too caught up in memorizing those. Just notice that it's central with plenty of muscle all around it in multiple planes. Early on, a simple sac does not mean it's a real pregnancy. You can see simple sacs or fluid collections that look like sacs in ectopics or in miscarriages and all kinds of things. So even though this is the first thing you'll see, this is not definitive of a pregnancy. This is just a gestational sac. And again, we said this already, pseudo-gestational sac can be seen in ectopic. Yolk sac, which we'll see next, is a double ring sign, is the first reliable pregnancy indicator. And it's important, if you find it, to then ask yourself, is it where it belongs? Is it in the right place? Talk about this briefly, the double decidual sign. In some radiology literature, this might be a reliable indicator of pregnancy, where you can see an echogenic rim around the yolk sac. Here it's fairly well defined. Here we probably actually see a yolk sac. We'll talk about that in a second. But if you see this double decidual sign, this may be more indicative of a true gestational sac. However, for most point of care and emergency medicine and family medicine and other indications, we don't typically rely on this. We'd like to wait until we see the true yolk sac. So that's what I'll talk about next. And here you can see these are very well defined. This is gestational sac, and within it we see the yolk sac. So the yolk sac sits inside the gestational sac. 2 rings. This is a true pregnancy indicator. Now you still have to be careful, make sure it's in the right place. Fairly central, fairly towards the fundus within the uterus, and plenty of myometrial muscle all around. Here's just a zoomed in picture, gestational sac, yolk sac, and I'll point out to you that in most cases a sac this small is not visible by transabdominal ultrasound unless you're in perfect ideal conditions. In most of our patients with less than ideal conditions, we need transvaginal ultrasound to identify this. So if I didn't say this already, and properly placed intrauterine yolk sac is the first reliable indicator of pregnancy. That's what we're going to stick with for our discussion today. So just some more examples. Transvaginal study, we see gestational sac, yolk sac within, and it's fairly centered and high up in the uterus. This is a coronal view, so again we can see it's fairly centered. We see plenty of thick myometrium or muscle surrounding it, so we don't have to be suspicious for an interstitial ectopic pregnancy. And then the next step that we'll see, so we start with gestational sac, maybe double decidual sign, then we get yolk sac, which is the first reliable indicator, and then the next thing we'll start to see is a fetal pole, which is like this little peanut within the uterus. We're still looking to make sure it's central, it's high, it's got plenty of muscle around it. Now we see the sac and this little tiny beginning stages of a fetus, and we can even measure crown to rump lengths to get ages on these things. And usually by the time you see this, you also should be able to pick up fetal cardiac activity. Make sure the pregnancy is in the uterus, and even further than that, make sure it's in the right place within the uterus. Fairly central, fairly high up towards the fundus. Plenty of myometrium around it in every plane. So pay attention to the rest of your anatomy and your landmarks. Don't just see a pregnancy and say, okay, it's good, and then you've neglected to realize that you saw a pregnancy, but it's over in the left adnexa somewhere. So first I'm going to just run you through this kind of complicated early pregnancy decision tree, and then I'll tell you how to make it easier. So the patient comes in with symptoms, obviously. If they're unstable, do a fast exam first to look for signs of ruptured ectopic, like blood, intraperitoneal blood, and then do transabdominal and transvaginal ultrasound as needed. If you see an intrauterine pregnancy, then it's either maybe they still have a ruptured heterotopic pregnancy or something else is going on. And there are plenty of other things: splenic artery aneurysms, ruptured spleen spontaneously, trauma, other weird things that might happen. But those are the things you have to think about. If they're unstable and you see an intrauterine pregnancy, maybe they're unstable for something else. They're septic, they've got PE, who knows. If they're unstable and you do your fast exam and your transabdominal, transvaginal ultrasound, there's no intrauterine pregnancy, then that is highly likely an ectopic, especially if you see free fluid within their abdomen. Now, let's say they're stable and their HCG is above, and you can pick, is it 1,000, 1,500, 2,000? People use different numbers. We'll say 1,500 to make it easy. You do your transabdominal, transvaginal ultrasound, and I would recommend just going ahead and doing the parts of the abdominal portions of the fast as well. If you see an intrauterine pregnancy and heterotopic is unlikely, or you've completely done a complete exam to look for heterotopic and you don't see one, then you can be done. If you don't see an intrauterine pregnancy and they're stable and they're above the HCG level, then you have to consider that to be an ectopic until you've proven it's not. And how do you prove it's not? Well, you can do more ultrasound yourself. You can refer them for radiology ultrasound. You can observe them. There's lots of other things you can do, and kind of beyond the scope of what we're talking about here today. Now, to make this easier, they're all pregnant, and if they have symptoms at all, they have an ectopic pregnancy until you prove they don't. And in most cases, if you diagnose an intrauterine pregnancy, then ectopic is really unlikely. But if you can't confirm an intrauterine pregnancy, ectopic is still on the list. So as far as your decision making, if you see a properly placed intrauterine pregnancy, and this is a low risk patient, so they're not a fertility patient, they're not in shock, then you can probably be done. Once you find an intrauterine pregnancy, you can probably just stop there. They can go home, they can be reassured, and they can get follow-up, and they can come back if their symptoms get worse or new symptoms come up. Second option here, they have a properly placed intrauterine pregnancy, but they're high risk, so they're a fertility patient or something like that, and heterotopic is still a possibility, or you're still worried about it. Then they need a complete ultrasound of complete views of their adnexa, and if you didn't do it already, the abdominal portions of a fast exam to look for ectopic or other signs. And again, beyond what we're going to talk about today, tune in another time for advanced first trimester ultrasound. And then also, there's lots of other reasons people have abdominal pain in the first trimester pregnancy, so think about that stuff too. Now, again, as far as introductory things, what we're going to say is if you don't find an intrauterine pregnancy, but it's a low-risk patient, and they have a low HCG, then they can get a follow-up. And the textbook answer is to do a 48-hour follow-up on these patients. Now, why 48 hours? Well, 48 hours is for the patient who you just did a uterine evaluation, but you didn't completely evaluate their adnexa, you didn't look at the FAST exam, so there's still other possibilities on the list, and they need explicit return instructions. Now, if you tune in for our advanced first trimester pregnancy decision making, we'll talk about doing the complete ultrasound yourself, and 48-hour follow-up and trending HCGs doesn't matter anymore. But when we're first getting started, this is the way to go. Start with the 48-hour follow-up and return instructions. If they don't have an intrauterine pregnancy, but they're a higher risk patient, or they have a HCG above 1,000, or maybe you use 1,500, whatever, then they need complete ultrasound. Now, if you have some practice under your belt and you can do that, you should do it. And I think primary care and emergency physicians should be capable of doing that, but not everybody's there yet. We'll get there. But if you can't or you're not comfortable, don't be a hero. Send them to radiology, ask gynecology to see them. If they're stable and it's nighttime and you want to let them wait till morning and come back at 7 or whenever, you can do that as well. But if there's no intrauterine pregnancy and they're either high risk or they have an HCG that's above your cutoff discriminatory zone, then somebody needs to do a complete ultrasound evaluation for this patient. Just a few tips about imaging. Find the bladder. It's a good landmark to help you then identify other structures. Make sure you look for the endometrial stripe. And a big mistake that sometimes can happen is just you miss part of the uterus. Make sure you see the whole thing, the fundus, the body, all the way down to the cervix. And I definitely recommend getting comfortable with and using transvaginal ultrasound, and just make it part of your practice. Don't be afraid of it. It really can open up a big window of diagnoses that otherwise you wouldn't be able to make. So I fully advocate being comfortable with transvaginal ultrasound. Some pitfalls to worry about. Just remember, you can have an ectopic at almost any HCG level, so don't say, well, the HCG is only 600, so they can't have an ectopic. That's not true. The HCG value does not really predict ectopic or not. Ectopics can be painless, especially before they rupture, so don't say if they don't have pain that you don't have an ectopic. Have to be careful about the interstitial ectopic. That's why it's important to, when you identify the intrauterine pregnancy, to pay attention to where it's located and make sure it's fairly central, fairly high, has an adequate thickness of myometrium all around it. Remember, if you do see something in the adnexa, ectopic might appear nonspecific, so it won't always look like a normal pregnancy in the wrong place. Sometimes it'll just look like a strange or complex mass over in the adnexa somewhere. And none of this really matters or is helpful if you haven't taken an adequate history. So even though I love ultrasound, it doesn't replace being a good doctor and taking good history. So make sure you've asked about heterotopic or other ectopic risk factors like fertility treatment, previous tubal surgery, I usually say prior pelvic infections or PID, things like that. If you haven't asked that stuff, you're not doing your job, and no ultrasound can compensate for you not doing your job and asking the right question. And remember, for our introductory stages, this is our guiding question: is there a properly placed intrauterine pregnancy? That's your goal. That's what you're trying to find. So just to summarize, we talked about doing transabdominal and transvaginal ultrasound. We're going to completely evaluate the uterus. We're going to locate our intrauterine pregnancy, make sure we know where it is in multiple planes, make sure it's central, plenty of surrounding myometrium. We're going to, even from the very beginning, we want to practice evaluating the adnexa completely, and I will talk about that more at a different time. And with everything in ultrasound, we're going to correlate with the whole clinical picture. So in first trimester pregnancy, we're going to use all the clinical data, all the questions that we ask, quantify their bleeding, what's the HCG level. We're going to put all that together to make decisions. And then lastly, in most patients, finding a properly placed intrauterine pregnancy makes ectopic pretty unlikely. So that's about all I have for you on the introduction to first trimester pregnancy ultrasound. I hope that was helpful. And like I said, this is just a little teaser. This will get you started, get you comfortable with the technique, and then I highly recommend that you practice more so that we can move on to advanced first trimester ultrasound and decision making and see more on that topic soon. Thanks a lot.